Hey guys, welcome back to Medical Coding with Blue. Today's episode is all about sequencing tips for medical coders. If you are brand new to my channel, welcome. I am Blue. I'm a medical coder. So I've been getting this question a lot from folks, and I'm going to preface this whole video with this. I'm going to be talking about the outpatient setting, all right? Just only the outpatient today because it's a lot of detail to get into the inpatient side. When you start talking about inpatient side, it's a completely different animal. For simplicity's sake, I am only going to be talking about the outpatient setting. So these would sort of apply to clinic visits, your outpatient clinic visits, or like the ER visits. That's what I'm talking about today. So let's get into it. All right. The first things first, when you're looking at an encounter in the outpatient setting, you need to start asking yourself the right question. Why is this patient here? So I always recommend that when you're looking at notes to always look at the assessment and plan. And the reason that I say this is because the assessment and plan is going to tell you everything that happened, everything that you need to know. It's going to be right there. Yes, a lot of people say just start at the history of present illness or the SOAP part. They're going to tell you to start up there. The subjective, right? Subjective, objective, assessment, and plan, okay? If you're working it that way. They tell you to start from the top and work your way down. Me personally, I start from the bottom and I work my way up. Trust me, when you are looking at notes all day long, you really start to get to the point where you're like, okay, let's get to the point. And that's the way that it is. So that way you can start to really get into the groove of things. But the reason that I like to look at the assessment and plan first is because that's where your final diagnoses are at. That's what's going to tell you, that's the end result of this entire visit. All of whatever they've done, their x-rays or anything like that, all of that final information is going to be right there. So then you're going to know what to look for. You're going to know how in-depth does this note need to be. So without totally going into another avenue, because it could totally turn into that, I'm going to stick with the subject. All right, so let's just say, for instance, the patient comes in because they slipped and fell on some ice, right? They're walking, they slipped and fell on some ice. They hurt their left ankle, okay? So their left ankle, it's hurting. They slipped, they fell on it, and it just hasn't been right ever since then. They can hardly walk on it. So the patient presents for care, and the assessment and plan says that the patient has an ankle fracture. Okay, I'm going to make it very simple. I'm not going to get into the big terms. Okay, so I'm just going to make it very simple today. Left ankle fracture. Okay, so that's what you're looking at, left ankle fracture, and they slipped and fell on some ice. So that's that. You have your injury code and you have how it happened, right? Because you should always have that. Your injury codes are always going to have an external cause code with them. Doesn't matter if they're on the initial visit, the subsequent visit, if they're in a sequela situation. You always need to know how did they get this injury, okay? Sometimes if the provider doesn't document this because they don't know, that's when you have to work with them about this is what we need to know when it comes to injuries. Again, I'm going to try to stay focused. So this patient has a left ankle fracture. That is the end result of all of their radiological workup. And they say, okay, they're going to put them in a cast. And so they cast them and they tell them to come back for their follow-up appointment to check and see how everything is going. So now you know that you're looking for that the patient had a fracture, ended up with a fracture, that they fell on the same, they fell on some ice, and they had a close treatment, okay? Let's just keep it simple. They had a close treatment. So when we look at the top where it starts with the history, right? We see that the chief complaint says that the patient is coming in with left ankle pain. Do you think that you're going to pick up this left ankle pain? No. Because that left ankle pain is an inherent part of that injury. Now, this is a brand new injury, and we know this because it's going to say in the assessment and plan that this is an initial, right? Just based on what they're talking about. And hopefully they've got all of this detail in there. This is an initial injury. This is when it happened. And so that way you know. So when it comes to brand new injuries like this, initial injuries, you're not going to pick up the pain. The only time that you might pick up pain is if this is a sequela situation. But again, I'm not going to talk about that right now because that's a completely separate thing. I'm just going to go based on what we got going here in this scenario. So this patient, chief complaint is left ankle pain. But we know now that this is because of a fracture. So sometimes they'll say, well, do I pick up the left ankle pain? And then do I pick up the left ankle fracture? No, you're going to pick up the left ankle fracture because, again, that pain is an inherent part of that injury. So that you got covered and out of the way. So we know now that we've got the injury code first, then we've got the external cause code. And then you have all of your other Y codes, right? Like your location and where it happened and what were they doing and that kind of thing. But I'm not talking about that other stuff right now. I'm just covering the basics, okay, of how do you know what to code, right? So taking that pain off the table, going with the fracture, going with the external cause code, all right? And then all your other like Y codes, talking about like where they were. But let's just throw in, well, this patient is also a diabetic and a smoker, all right? Same patient, diabetic and a smoker. So again, starting with the left ankle fracture, starting with the left ankle pain, right? And we know it's a fracture, so we're going to code the fracture code first, that S code, because all of your injury codes are going to start with, well, in this situation, it's going to start with an S, all right? Because there's some other injury codes that are different, okay? But for this one, it's going to start with an S and it's going to end with an A because this is the initial visit, all right? And then the patient is a diabetic and they are a smoker. So thinking of this, how would we sequence the smoking? How would we sequence the diabetes in relation to this fracture? Well, we know that the reason that the patient came in was because of their left ankle pain, which turned out to be an ankle fracture. So that ankle fracture is going to go first. Now, what if the provider says the patient's diabetes levels were reviewed, their blood sugars are under control, and they are taking their medication as needed and as normal. They are sticking to a strict diet and they are doing exercise, and so everything is fine there. So we know their diabetes is under control, all right? And along with this diabetes, they're also taking long-term use pills to keep it under control, okay? And there's many out there, so I'm just going to say that. And then with this smoking, now the provider says, well, the patient is a smoker, and I counseled them, and they're going to say, I counseled them for 5 minutes about the dangers of smoking and how it's going to affect their ability to be able to heal from an ankle fracture. And he goes into all of this detail about it, all right? So if he does this, then of course, obviously, you can give him an evaluation and management for the treatment of the ankle fracture. And for talking about the diabetes, you can give him the tobacco cessation counseling as long as he has the appropriate statement in there along with his minutes, however many minutes he spent. Because if you look at the description of the code, it says specifically that it has to be greater than 3 minutes. So the provider cannot put, I spoke greater than 3 minutes. They need to be very specific. Was it 4 minutes? Was it 5 minutes? It needs to be very concrete and it has to be very clear. It cannot be, I spent greater than 3 minutes. That's too ambiguous. We need to know exactly how much time you spent. So we're still going. Okay, we're still going. All right. But so we have the fracture first. Then we have the diabetes, because that diabetes is going to impact that provider's ability to take care of this patient, right? Because if the patient had out of control diabetes, think about that. They would be, having to think of other alternative things to be able to take care of them. But because he reviewed the information and this patient is okay and they are diet controlled and, they're just taking their medications like they're supposed to, then we know that that patient is perfectly fine. So it would be the fracture first, then followed by the diabetes. Now we have this tobacco cessation, right? We have the tobacco, if they're a cigarette smoker. And so we have the long-term current use, the tobacco dependence. Sorry, guys. The tobacco dependence code. So then with that in mind, right, we've got that going. Then we have our external cause code, and then you have your Y codes. So your external cause codes are always going to be anchored at the bottom, right? Followed by like your Y codes, because those are, I'm not going to say they're not important, because it is important. It's got to be there. But in terms of sequencing, it's not going to go with that, with the injury code as a second listed diagnosis if there's other things that are going on, because that external cause code can go at the end. When it comes to how you sequence, think about this. The patient had the fracture. The diabetes could potentially directly affect that fracture because of the healing time and all this, and the provider's ability to make decisions to take care of this patient. That's why this is an important diagnosis, and this is why it's going to go second. And then you have the tobacco dependence. So then you have that as the third listed diagnosis, because it's still impactful. But to me, when it comes to how to think about these things, the patient is probably has a lot more to do with taking care of their diabetes than being a smoker, even though the smoker is just as bad as on their health, right? Or as impactful on their health. So that's why I would say the diabetes would go next, followed by the tobacco, followed by the external cause code for that they fell, and then all of your Y codes, activity codes, and so on and so forth. So that's how I would do that. But, and also I forgot the long-term use pill for their diabetes, that would be anchored underneath the external cause code. So there's the external cause code, the long-term use medication code, and then your Y codes. So that would be how I would sequence those, because of the way of the importance. And when you start to think about like how important are diagnoses in relation to a diagnosis, whatever principal diagnosis they're coming in with, or whatever chief complaint they're coming in with, when you think of it like that, that is when it's going to start to make more sense. Well, this outweighs this, and this one is going to outweigh this one. Or if you have, those combination codes, then you're going to put them in there by the order that the book is telling you, because it'll let you know code first this diagnosis, or code first this, or code next this, right? Code additional code for like the whatever infection, if it's whatever, and then like the specific thing that's causing the infection. So that's another way to look at it. But I know it gets a little like, ooh, how do we do this? It will get easier, guys. I mean, honestly, it will. And don't get too hung up on like if the patient has a lot of different conditions going on, and then you're like, well, how do I, do all of these? As long as you've got your top ones, the ones that they're doing the most work on, the ones that they are putting the most thought and care into, that's the way you're going to be able to know that these diagnoses are more important, and they have to be anchored first. But to find the principal diagnosis, or the chief diagnosis that you're going to report first, always think about, why is this patient coming in? And if it's in a situation like an injury and they say pain first, well, then you're going to be reporting the injury code and not the pain, unless it's a sequela. If it is a sequela, and that's that on that one, okay? But if it is a sequela, now what is a sequela? A sequela is what happens after you've gone your normal course of your injury, right? And a sequela can occur at any time. So if, let's just say, for example, you get post-traumatic osteoarthritis, right? Same patient, let's do same patient. This same patient that broke their ankle, right? A year later, they came back and they say, well, after I got out of the cast for my ankle, I still continue to feel some kind of pain, and it's still there. It's a dull pain, but it's just constant. So they do their workup, and they find that the patient has post-traumatic osteoarthritis from the fracture. So the provider says, the patient had a fracture, whatever the date was, right? And they say, well, over time, this has developed into post-traumatic osteoarthritis as witnessed on the radiology workup. And so in that situation, if they're coming in because they say they feel pain, that's going to be that post-traumatic osteoarthritis, because we know that that is what's causing that. So post-traumatic osteoarthritis, followed by the sequela for the fracture of that ankle, because that's what the provider is saying that is related to that. So that would be when you would report something like that. But let's just say that they didn't quite have post-traumatic osteoarthritis yet. So that's off the table. And they just have pain. There's nothing there, but it's just painful, right? And it could be achy. You know, that's common, right? So it's a year later, same patient, right? Different scenario, right? So they came in with ankle pain, left ankle pain, and they had this fracture, and the provider says, well, this patient says that the pain is related to their fracture because they never feel like the pain actually went away. They've always kind of had this dull pain ever since they had this fracture. So then in that instance, you would put the pain, the left ankle pain, followed by the fracture code with the sequela, with the S at the end, right? And then you would put the fall. If hopefully the provider puts that they fell and that was how they fractured their ankle. So that would be when you would report the pain, the injury code with the sequela at the end, and then the external cause code with the sequela at the end. That would be when you would report pain. But a lot of times people think, well, they came in with the pain, so I'm going to report the initial fracture code or initial injury code, and in conjunction with the pain. No, that's overcoding at that point. If that is the first time that they're being seen for it, and this is not a sequela situation, and you're trying to stick that pain on there, that pain is an inherent part, so you wouldn't pick that up. So that is something to keep in mind as well. When you start to work with injuries, it's very important to know, which is why I am constantly making sure that my providers understand that it is very important for me to understand and know where this patient is in their care. Is this the first time that this patient is being seen for this injury? Has this injury happened before? You know, what happened? When did it happen? Who, what, when, where? I need to know it all. And so they go, okay, Bleu. And so they start putting all this information in there. The more information that you can get from your provider and the more that they can get used to that, the better off it's going to be for you, for the patient most of all, and for the provider, because at least you're going to know where they are in their care. And the provider is going to be covered because all this information is already there. They don't have to think about this stuff later on, like, when did this patient have this? And, you know, because sometimes when the patient is giving their history, things can change. If they have a very good documentation already, they can rely on their notes. And so that is very important for the provider to know as well, because it's not always going to be easy, you know, and sometimes patients, they're in pain and they can't remember all of this stuff. I don't remember. So if it's already documented, that takes a lot of pressure off of, okay, we can concentrate on taking care of the injury rather than all this other paperwork stuff that we've already gone over. Okay, so that is some tips on that. When you have something as simple as, let's say, a cold, a patient's coming in with a cold, okay? They're coming in with a cold, but they also have hypertension, okay? They're presenting with the sniffles. They've got a runny nose, cough, a fever. And so at the end, the provider diagnoses them with just a cold, just a regular common cold. You're not going to pick up all of those things, the runny nose, the fever, the sneezing. You're not going to pick that up because that's covered under the cold, okay? Those are all symptoms of a cold. And then you have your hypertension. Now, hypertension is a very serious diagnosis. Yes. You know, patients are on medication can be on medication for hypertension, right? So this is very serious, but that's not the reason that the patient presented for care. The patient presented for care for a common cold. So if the provider says, well, hey, how you doing on your, it says here you have hypertension. How are you doing? Well, my blood pressure is under control and everything is fine. And I take my medication like I'm supposed to. Bingo. So we have our common cold, and then we have our hypertension diagnosis. Okay. And then if they talk about the medication that they're on, then you could put the long-term use medication code on there too, as well. So that you're good to go. So that would be how you would be able to decide those things. But when you have symptoms, and in the outpatient setting, if we have a definitive diagnosis, right, then we know we're going to report that definitive diagnosis. If there's any symptoms that are listed and they are a part of that definitive diagnosis, then we know that we're not going to report those symptoms, right? And that is a staple in the outpatient setting. So it will get easier, but you just have to ask yourself, why is this patient coming in? And when you know that, that's when you know you got your first one, right? Then you got to think about, okay, all these other diagnoses that are listed here, how do they relate to this diagnosis? How related are they? And again, going back to the fracture, and the patient was a diabetic and a smoker, right? And then the diabetes is obviously going to impact that. I mean, the smoking can impact that too, but there was a little bit more work involved with the diabetes in that situation. So that would be why you would report that one that way. Okay. So again, it gets easier, and honestly, it is fun when when you start to look at it and you're like, oh, okay. But getting those first 4 right is where it trips up a lot of people, because after a while it gets easier, right? As you go along, if there's more diagnoses, it does get easier. But it's those first 4 heavy hitter ones that it's just like, how do we do this one? But if you get stuck, there is a section, if you use the Optum 360 coding books. This is not an ad for Optum 360. And you guys have heard me say this 100 times. Look in the appendixes of the Optum 360 coding books. I'm telling you guys, there is a lot of really good information there. And there's a lot of information about first listed diagnoses as well. A lot of that stuff will help you. And there's going to be things that you're not going to report as a first listed diagnosis ever, like long-term use medications. You'll never report that as a first listed diagnosis ever. It has to be what is going on, right? And if there's no diagnosis, then you got to send a query like, what's going on here, you know? But there's going to be those things that you learn, but taking the time to look in books like Optum 360 is really going to help you. Yes, there are other publishers out there for the ICD-10-CM books. I can't vouch for anybody else but Optum 360. I trust their books, and I love their books. I love their books. But I like it because there's so much detail in there. So if you haven't had a chance to check any out, I'm telling you guys, you really should. And they're still having their sale. So if you are interested, I will leave the link for the Optum 360 website. Check it out. I mean, it's just the books are a cheaper rate right now because they're all on sale still. At least I think they're still on sale. But I'm pretty sure, because I just looked the other day and they were still on sale, and they have a phenomenal sale going on right now. So just saying. I'm going to wrap this one up, but I hope you guys enjoyed this. I hope this was helpful for you. If it was, I hope that you'll hit that subscribe button and like this. Please share it if it helped you, if you found value in it. And I will see y'all on the next video. Bye.